Hello everyone, a blessed and wonderful day to all of you. So, this video is the second part of the physical examination of the nervous system. So before we proceed with our discussion, let me again present to you this disclaimer slide. So again, this is the second part of the physical examination of the nervous system. And these are the learning objectives of this presentation. Okay, so to continue with the physical examination of the cranial nerve number 12, the hypoglossal, you have to listen to the articulation of words of the patient. This depends on the cranial nerves number 5, 7, 9, and 10 as well as the cranial nerve number 12. And then inspect the patient's tongue as it lies on the floor of the mouth. Okay, for its position. Okay, look for any atrophy or fasciculations. Some cursor riskless movements are often seen in normal tongue. Okay, so when tongue protruded, you have to check for asymmetry, atrophy, or deviation from the midline. And then you have to move the tongue from side to side, okay, and check for asymmetric movement. As you assess the motor system, focus on the body position. Observe for involuntary movements, characteristic of the muscles like the bulk, the tone, and the strength, and the coordination. Okay. Observe also for tremors, tics, chorea, fasciculations, and note for location, quality, rate, rhythm, amplitude, and relation to posture, activity fatigue, and emotion and other factors. Okay, again, for the motor system, you assess for the muscle bulk, the muscle tone, and the muscle strength. And also assess for coordination. Okay, so the coordination of the muscle movement requires that four areas of the nervous system, okay, such as the motor system for muscle strength, the cerebellar system, which is also part of the motor system, for rhythmic movement and steady posture, the vestibular system for balance and coordination, and the sensory system for position sense. Okay. So to assess for coordination, you have to observe the patient performance for rapid alternating movements, point-to-point movements, gait, and other related body movements, and standing in specific ways. In those who have cerebellar disease, you have to look for nystagmus, dysarthria, hypotonia, and ataxia. So still part of the motor system, or the physical examination of the motor system, is also to assess the rapid alternating movements by showing the patient how to strike one hand on the thigh. Raise the hand, turn it over, and then strike the back of the hand on the same place. Urge the patient to repeat these alternating movements as repeatedly as possible. And then you have to observe the speed, the rhythm, and smoothness of the movements. Repeat with other hand. The non-dominant hand often performs somewhat less well. In those with cerebellar disease, instead of alternating quickly, these movements are slow, irregular, and clumsy, and this abnormality is called as dysdiadochokinesis. The upper motor neuron weakness and basal ganglia disease may also impair rapid alternating movements, okay, but not in the same manner. So another way of assessing the motor system is by point-to-point movement. So we have arms and legs. Okay, for the arms, we have fingers to nose test. For the legs, we have heel to shin test. Okay, for the arms, you have to instruct or ask the client to touch your index finger and then his or her nose alternately several times, and then move your finger about so that the patient has to alter direction, and then observe the accuracy and smoothness of the movements and watch for any tremor. So normally the patient's movements are smooth and accurate. For those who have cerebellar disease, movements are clumsy, unsteady, and inappropriate in their speed, force, and direction. So for the legs, okay, heel to shin test, you can ask the patient to place one heel on the opposite knee and then run it down the shin to the big toe. Observe the smoothness and accuracy of the movements. Repetition with the patient's eyes closed test for position sense, and then repeat on the other side. To those who have cerebellar disease, the heel may overshoot the knee and then oscillate from side to side down the shin. If the patient's sense is absent, the heel lifts too high, and the patient tries to look with eyes closed, performance is very poor. So another way of assessing the motor system, again for point-to-point movements using gait, you can ask the patient to walk across the room or down the hall, then turn and come back. You observe posture, balance, swinging of the arms, and movements of the legs. Normally, balance is easy and the arms swing at the sides and turns are accomplished smoothly. Abnormalities of the gait increases risk of falls. So, a gait that lacks coordination with drilling and instability is called ataxia. And ataxia may be due to cerebellar disease. So, another way of testing the point-to-point movement is stance. There are two tests that often perform, such as the Rombert's test and the test for pronator drift. Okay, so they differ only in the patient's arm position and in what is assessed. Okay, so this is mainly the test of position sense, wherein the patient should stand with feet together and the eyes open and then close both eyes for 30 to 60 seconds without support. And then the nurse should stand next to the patient without touching him or her, just in case the patient lost balance, with arms in front and back of the patient. Note the patient's ability to maintain the upright posture. Normally, only minimal swaying occurs. To test for pronator drift, the patient should stand for 20 to 30 seconds with both arms straight forward, palms up, and the eyes is closed. Okay. A person who cannot stand may be tested for a pronator drift in the sitting position. In either case, a normal person can hold his arm position well. So, pronator drift is the pronation of one forearm. If the both or it is both sensitive and specific for a corticospinal tract lesion. So now let's proceed to the abnormalities of the gait and posture. We have very spastic hemiparesis that is usually seen in corticospinal tract lesion in those who have stroke, causing a poor control of flexor muscle during swing phase. Affected arm is flexed, immobile, and held close to the side with elbow, wrist, and interphalangeal joints flexed. Affected leg extensors spastic, ankle plantar flex and inverted. Okay, patients may drag toe in circle, legs stiffly outward and forward, or my circumduction, or lean track to contralateral side to clear affected leg during walking. So another abnormalities of the gait is the scissors gait that is usually seen in spinal cord disease causing bilateral lower extremity spasticity, including adductor spasm and abnormal proprioception. The gait is stiff. Patients advance each leg slowly, and the thighs tend to cross forward on each other at each step. Steps are usually short, and the patients appear to be walking through water. Another abnormalities here is the steppage gait that is seen in foot drop, usually secondary to peripheral motor unit disease. The patients either drag the feet or lift them up, as you can see in this picture, with knees flexed and bring them down with a slap onto the floor, thus appearing to be walking up in the stairs. They cannot walk on their heels. The steppage gait may involve one or both legs. The tibialis anterior and the toe extensors are weak. So another abnormality here is the Parkinsonian gait that is seen in basal ganglia defects of those who have Parkinson's disease. The posture is stooped with flexion of the head, arms, and hips and the knees. The patients are slow getting started. Steps are short with and shuffling with involuntary hastening or festination. The arm swings and decreased, and the patients turn around stiffly, all in one piece. So the postural control is poor, so there is anteropulsion or retropulsion. So another abnormality here is the cerebellar ataxia that is usually seen in disease of the cerebellum or associated tracts. Gait is staggering, unsteady, and wide-paced, with exaggerated difficulty on turns. Patients cannot stand steadily with feet together, whether eyes are open or closed. Other cerebral signs are present such as dysmetria, nystagmus, and intention tremor. So we have also another abnormality here, the sensory ataxia that is seen in loss of position sense in the legs with polyneuropathy or posterior column damage. The gait is unsteady and wide-paced with feet wide apart. The patients throw their feet forward and outward and bring them down, first on the heels and then on the toes, with a double tapping sound. They watch the ground for guidance when walking. With eyes closed, they cannot steadily walk with feet together. That's called positive lumbar sign. And of course, there is staggering gaits, or the staggering gaits worsens. Now moving on to the physical examination of the sensory system, you have to test the following, no? The pain and the temperature for spinothalamic tracts, the position and vibration for posterior columns, light touch for both spinothalamic and posterior, discriminative sensations to check for cortex, spinothalamic tracts, and the posterior column. So, you have to correlate your abnormal findings with motor and reflex activity. Is there underlying lesion in the central or peripheral? Is there sensory loss that is bilateral or unilateral? Does the pattern suggest dermatomal distribution or a polyneuropathy or a spinal cord syndrome? Is there loss of pain and temperature sensation, intact touch and vibration? To continue with the sensory system, physical examination, okay? We know that sensory testing quickly fatigues many patients and can produce unreliable results. You have to conduct the examination as efficiently as possible. Okay? You have to pay attention, or you have to focus on the areas that have numbness or pain, motor or reflex abnormalities, and if there is abnormal findings. Okay, so to continue with the physical examination for the patterns of testing, you can compare symmetric area, for example, left and right. Okay, compare the distal with proximal areas, and then test fingers and toes first for vibration and position. So it varies the pace of your testing. And you have to map out boundaries if sensory loss or there is hypersensitivity. Okay, to assess for pain or patterns of pain, you can use broken tongue blade to test for sharp and cotton swab for dull. And you can apply lightest pressure needed for stimulus to feel the sharp, and of course, do not draw blood. So, testing is often omitted if the pain sensation is normal. But if there are sensory deficits, you can use two test tubes and you can fill it with hot and cold water. Or you can use a tuning fork heated or cooled by a running water. And then you can touch the skin and ask the patient to identify if it is hot or cold. For light touch, you can use cotton, and you can touch the skin lightly, avoiding pressure, and then you can ask the patient to respond whether a touch is felt and to compare one area with another. So make sure to avoid testing on the callous skin, which is of course normally relatively insensitive. So for testing the vibration, you can use a relatively low pitch tuning fork of 128 Hertz, and then you can tap it on the heel of your hand and place it firmly over a distal interpharyngeal joint of the patient's finger or toes, and you can test it also over the interpharyngeal joint of the big toe. And you can ask what the patient feels. If you are uncertain whether it is pressure or vibration, you can ask the patient to tell you when the vibration stops and then touch the fork to stop it. Okay, to test for proprioception or position, you can grasp the big toe of the patient, holding it by its sides between your thumb and your index finger, and then you can pull it away from the other toes. This prevents extraneous tactile stimuli from affecting testing, and then you can demonstrate up and down as you move the patients to clearly upward and downward. Then with the patient's eyes closed, you can ask for a response of is it up or down when moving the large toe in a small arc. So the loss of position sense, like loss of vibration sense, could suggest problem or there is a multiple sclerosis or B12 deficiency. So there are several additional techniques to test the ability of the sensory cortex to correlate, analyze, and interpret sensations. Because discriminative sensations depend on the touch and position sense. They are usually useful when these sensations are either intact or only slightly impaired. If touch and position sense are normal, decreased, or absent, discriminative sensations indicates a lesion in the sensory cortex. Stereognosis, number identification, and two-point discrimination are also impaired in those who have posterior column disease. Okay, so stereognosis refers to the ability to identify an object by feeling it. For example, you have to place a familiar object such as a coin, paper clip, key, pencil, or cotton ball in the patient's hand. And you can ask the patient to tell you what is it. Normally, of course, a patient will manipulate it skillfully and identify it correctly within 5 seconds. You, you can also ask the patient to distinguish the heads from the tails of a coin. Okay, that is to test also for stereognosis. For number identification, or this is also known as graphesthesia, so if arthritis or other condition prevents the patient from manipulating an object to identify it, you can test the ability to identify numbers by using a blunt end of a pen or pencil. You can draw a large number in the patient's palm. Okay, so generally, the person can identify most of the numbers na sinusulat mo dyan. For two-point discrimination, you can use two ends of an open paper clip and then touch a finger pad in two places simultaneously, then alternate the double stimulus irregularly with a one-point touch. Be careful not to cause, of course, pain. So, lesions of the sensory cortex increase the distance between two recognizable points. For point localization, you can briefly touch a point on the patient's skin, then ask the patient to open both eyes and point to the place you touched. Generally, of course, the person can do so accurately. This test, together with the test for extension, is especially useful for the trunk and the legs. Okay, for extension, you can do this by simultaneously stimulating the corresponding areas on both sides of the body. You can ask the patient where she or he feels your touch. Of course, normally both stimuli are felt. So under your physical examination of the sensory system is the dermatomes. Remember that knowledge of dermatomes helps you localize neurologic lesions to a specific level of the spinal cord, particularly in spinal cord injury. So dermatome is the band of skin innervated by the sensory root of a single spinal nerve. So the dermatome and the peripheral nerve patterns are illustrated in this image. Okay, so this is another image of the posterior dermatome. So we don't need to memorize all the dermatomes. Instead, we have to focus on selecting selected dermatomes such as those specifically named on the diagram. With that, let's move on to the physical examination of the muscle stretch reflexes, or known as the deep tendon reflexes, or the DTR. So, you need the following equipment: a properly weighted reflex hammer. And eliciting the muscle stretch reflexes requires a special handling of the reflex hammer. And of course, you have to encourage the patient to relax, and then you have to hold the reflex hammer loosely between the thumb and the finger. With wrist relaxed, you can strike the tendon briskly and note the speed, force, and amplitude of reflex response. Okay, so first scale for grading reflexes we have here. For positive, if very brisk, hyperactive with clonus or rhythmic oscillations between flexion and extension. 3 positive kapag brisker than average or passively but not necessarily indicative of disease. 2 positive if average or normal, and 1 positive if somewhat diminished or low normal. 0 if no response. So we have here an example to test for muscle stretch reflexes or the deep tendon reflexes. For example, here the pointed end is useful for striking small areas such as your finger as it overlaps the biceps tendon. You can test the reflex by encouraging the patient again to relax, then position the limbs properly and symmetrically. Then you can hold the hammer or the reflex hammer loosely between your thumb and your index finger so that it swings freely in an arc within the limits set by your palm and your fingers. With, of course, your wrist relaxed, you can strike the tendon briskly using a rapid wrist movement. Your strike should be quick and direct, not glancing. And then you have to note the speed, the force, the amplitude of the reflex response, and you grade the response using the scale in the previous slide. Always compare the response of one side with the other. So again, the reflexes are usually graded on 0 to 4. Hyperactive reflexes or hyperreflexia in central nervous system lesions along the descending corticospinal tract. You can look for associated upper motor neuron findings of weakness, spasticity, or a Babinski sign. If the patient's reflexes are symmetrically diminished or absent, You can use reinforcement, which is a technique involving isometric contraction of other muscles for up to 10 seconds that may increase reflex activity. In testing for the arm or arm reflexes, for example, you can ask the patient to clench his or her teeth or to squeeze one thigh with the opposite hand. If leg reflexes are diminished or absent, reinforce them by asking the patient to lock the fingers and pull one hand against the other. And then tell the patient to pull just before you to strike the tendon. Okay, so to continue with our TTR, for the biceps reflex to check for the C5 and C6, the patient's elbow should be partially flexed and the forearm pronated with palm down. You can place your thumb or finger firmly on the biceps, as you can see in this picture. Aim the strike with the reflex hammer directly through your digit toward the biceps tendon. You have to observe for flexion at the elbow and watch for and feel the contraction of the biceps muscle. Okay, to test for triceps reflex for C6 and C7, the patient may be sitting or supine. You can flex the patient's arm at the elbow with palm toward the body. Okay, and pull it slightly across the chest, as you can see in this image. Then strike the triceps tendon with a direct blow directly behind and just above the elbow. And watch for contraction of the triceps muscle and extension at the elbow. If you have difficulty getting the patient to relax, try supporting the upper arm. Okay? Ask the patient to let the arm go limp, as if it were hung up to dry. Then strike the triceps tendon. Okay, so to test for brachioradialis reflex for C5 and C6, the patient's hand should be on rest on the abdomen or at the lap, with the forearm partly pronated. Strike the radius, as you can see in this picture, with the flat or the point edge of the reflex hammer, about 1 to 2 inches above the wrist. You have to watch for flexion and supination of the forearm. Now to test for the quadriceps or patellar reflex for L2, L3, and L4, the patient may be either sitting or lying down as long as the knee is flexed. Briskly tap the patellar tendon just below the patella, and then note the contraction of the quadriceps with extension at the knee. And then you can place your hand on the patient's anterior thigh to feel this reflex. There are two options for examining the supine patient. You can support both knees at once. Okay. Allows you to assess small differences between quadriceps reflexes by repeatedly testing one reflex and then the other. If supporting both legs is uncomfortable for you or the patient, you can place your supporting arm under the patient's legs. Some patients find it easier to relax with this method. Okay, so to test for Achilles reflex or the ankle reflex, primarily for S1. So if your patient is on sitting position, you can partially dorsiflex the foot at the ankle. Persuade the patient to relax. Strike the Achilles tendon and watch and feel for plantar flexion at the ankle. Also note the speed relaxation after muscular contraction. When the patient is lying down, as you can see in this picture, you can flex one leg at both hip and knee and rotate it externally so that the lower leg rests across the opposite shin. Then dorsiflex the foot at the ankle and strike the Achilles tendon. If the reflexes seem hyperactive, test for ankle clonus. Support the knee in partly flexed position, as you can see in this image, with your other hand. Dorsiflexed and plantar flex the foot a few times while encouraging the patient to relax, and then sharply dorsiflex the foot and maintain it in dorsiflexion. Look and feel for rhythmic oscillations between dorsiflexion and plantar flexion. Normally, the ankle does not react to this stimulus. There may be a few clonic beats if the patient is tense or has exercise. Okay, so another test is cutaneous or superficial stimulation reflexes. So test the abdomen reflexes by slightly but briskly stroking each side, as you can see in this picture, above T8, T9, and T10, and below T10, T11, and T12, or in the umbilicus, in the directions as illustrated in this image. You can use a key, a wooden end of a cotton tip applicator, or a tongue blade twisted and split longitudinally. And you have to note the contraction of the abdominal muscles and deviation of the umbilicus towards the stimulus. Obesity may mask an abdominal reflex. In this situation, use your finger to retract the patient's umbilicus away from the side to be stimulated, and feel with your retracting finger for the muscular contraction. Okay, so for plantar response, okay, you can use a key, a wooden end of an applicator stick, or an end of a tongue blade, and then you stroke from the heel, moving up toward the small toe to the ball of the foot, curving medially across the ball. So use the lightest stimulus that will provoke a response, but increase firmness if necessary. Closely observe movement of the big toe, normally a plantar flexion with the toes curving down and inward. Dorsiflexion of the big toe and fanning of the other toes is a present Babinski response, arising from a central nervous system lesion affecting the corticospinal tract. So the Babinski response can be transiently found in unconscious states from drug or alcohol intoxication and during the postictal period following a seizure. So to assess for stuporous or comatose patient, okay, coma means a state of impaired arousal and awareness that signals a potentially life-threatening event affecting the two hemispheres, the brain stem, or both. Therefore, accurate assessment is critical. Although the arousal and awareness functions are interrelated, a change in one is not always associated with a similar change in the other. Okay, you can use the following technique of assessing the patient. First, you have to assess and stabilize the ABCs or the airway, breathing, and circulation. Then establish the patient's level of consciousness and perform neurologic examination. Identify the focal or asymmetric findings and determine if the cause of impaired consciousness is just structural or metabolic. Interview the relatives, the friends, or witness to establish the speed of onset and duration of unconsciousness. The warning symptoms, precipitating factors, or previous episodes and the prior appearance and behavior of the patient are helpful. Any history of past medical and psychiatric illness is also useful. Okay, so let's move on to special techniques of assessing a stiperous or comatose patient. During the examination, remember two cardinal thoughts. Okay, don't do the following. When assessing a comatose patient, do not dilate the pupils. Okay, paano ba mag-dilate ng pupils? They're actually using eye drops or mydriatric drops. No? Don't flex the neck if any question of trauma to the head or neck. You have to immobilize the cervical spine and get an X-ray first to rule out fractures of the cervical vertebrae that could compress and damage the spinal cord. You can also check the pupillary size, okay, equality, and light reactions that help you assess the cause of the coma and in determining the regions of the brain that is impaired. Remember that unrelated pupillary abnormalities including myotic drops for glaucoma or mydriatic drops for a better view of the ocular fundi may be preceded of coma. So a small or pinpoint pupils, okay, or bilaterally small pupils with a size of 1 to 2.5 millimeter could suggest damage to the sympathetic pathways in the hypothalamus, or metabolic encephalopathy, or a diffuse failure of cerebral function that has many causes, including drugs. Okay. A small pinpoint pupils of less than 1 millimeter could suggest a hemorrhage in the pons or the effects of morphine, heroin, or other narcotics. So the light reactions may be seen with a magnifying glass. For mid-position fixed pupils, the pupils that are in mid-position or slightly dilated, the size between 4 to 6 millimeter and are fixed to light suggests structural damage in the midbrain. Okay, so large pupil. Okay, bilaterally fixed and dilated pupils may be due to severe anoxia and its symptomatic effects, as seen after cardiac arrest. This can also be an effect of antidepressant drugs. One large pupil that is fixed and dilated warns of herniation of the temporal lobe causing compression of the oculomotor nerve in the midbrain. A single large pupil is commonly seen in diabetic patients with infarction of the cranial nerve number 3. Okay. Quickly check the patient's color and pattern of breathing and inspect the posterior pharynx and listen over the trachea for stridor to make sure that the airway is clear and not obstructed. Okay, if respiration starts slowed or shallow, or if the airway is obstructed by secretions, consider intubating the patient as soon as possible while stabilizing the cervical spine. Assess the remaining vital signs, the blood pressure, the pulse, and the rectal temperature. If hypotension or hemorrhage is present, establish an intravenous access and begin intravenous fluids. Now to assess for the level of consciousness. Okay, the level of consciousness primarily reflects the patient's capacity for arousal or wakefulness. So testing these targets is the level of activity that the patient can be aroused to perform in response to escalating stimuli from the examiner. So there are 5 clinical levels of consciousness that are described in the slides with related techniques for examination. So, increase your stimuli in a stepwise manner depending on the patient's response. When you examine the patients with an altered level of consciousness, describe and record exactly what you see and hear. Imprecise use of terms such as lethargy, obtunded stupor, or coma may mislead other examiners. Okay? For alertness, you can alert the patient, open eyes, looks at you, and responds fully and appropriately. If the patient is lethargy, the patient appears drowsy but can open their eyes, looks at you, responds to questions, and falls asleep. For obtunded patient, they usually open their eyes, looks at you, responds slowly, and is somewhat confused. For stupor patient, the patient arouses from sleep only after painful stimuli. Verbal responses are slow or absent. The patient lapses into unresponsive state when stimulus ceases and has minimal awareness of self or environment. A comatose patient is unarousable and the eyes are closed. There is no evident response to inner need or external stimuli. Okay, so imprecise terms may mislead other examiners. Then the Glasgow Coma Scale, or a standardized tool for objective assessment of patients, should be used. Here, there is a numeric value assigned to three different components of eye opening, motor response, and verbal response. Each area receives a score, and all the scores are then added together. So, lalagyan mo ng score dito to determine the level of brain function. Here, no, for example, for the activity, no, eye opening, so none, the score is 1. Okay, to pay, nagre-respond siya to pain. The score is 2. To speech, 3. Okay. For spontaneous, 4. Meaning the eyes open and not necessarily aware. So for the motor response, okay, 1. No response to any pain or limp, and the limp is flaccid. Okay. There is extension. Okay. The score is 2 if the shoulder adducted or the shoulder and the forearms internally rotated. Okay, flexor response 3 if there is a withdrawal response or assumption of hemiplegic posture. For motor response continuation ng withdrawal, 4 ang score if the arms withdraws to pain, shoulder abducts. To localize pain, the score is 5 when the arms attempts to remove or there is supraorbital or chest pressure. The score is 6 if able to obey command or can follow simple commands. For verbal response, the highest score is 5, meaning it converses and is oriented. The lowest score is 1, meaning there is no verbalization of any type. Okay, so the points are determined to assess the level of consciousness and coma in 3 areas: the eye opening, the verbal response, and the motor response. And these are the interpretation. Okay, for example, 3, no response. 3 to 8 could mean comatose. No, this is the for total score. 15 if the patient is fully alert and functioning person. So another way of assessing the stupors or comatose patient is also to evaluate neurologic or assess neurologic evaluation. For respirations, pupils, ocular movement, and oculocephalic reflex. For respirations, you have to observe the rate, the rhythm, and the pattern of respirations. Because neural structures that govern breathing in the cortex and brainstem overlap those that govern consciousness. Abnormalities of respirations often occur in coma. So for pupils, observe the size and equality of the pupils and test the reaction to light. The presence or absence of the light reaction is one of the most important signs distinguishing a structural from metabolic cause of coma. The light reaction often remains intact in metabolic coma. So, structural lesions from stroke, bleeding, abscess, or tumor mass may lead to asymmetric pupils and loss of light reaction due to pressure on the cranial nerves. For ocular movement, observe the position of the eyes and eyelids at rest. Check for horizontal deviation of the eyes to one side or gaze preference. When the oculomotor pathways are intact, the eyes look straight ahead. In structural hemispheric lesions, the eyes look at the lesion in the affected hemisphere. In irritated lesions from epilepsy or early cerebral hemorrhage, the eyes look away from the affected hemisphere. This reflex helps to assess the brainstem function in the comatose patient. By holding open the upper eyelid so that you can see the eyes, turn the head quickly, first to one side and then to the other side. Make sure the patient has no neck injury before performing this test. In a comatose patient with absence of Dahl's eye movement, the ability to move both eyes to one side is lost, suggesting a lesion of the midbrain or pons. In a comatose patient with an intact brain stem, as the head is turned, the eyes move toward the opposite side, known as the Dahl's eye movement. In the photo, for example, the patient's head has been turned to right. Her eyes have moved to the left. Her eyes still seem to gaze at the camera. The Dahl's eye movement are intact. Okay, so part of the neurologic evaluation is to assess for posture and muscle tone. Okay, observe the patient's posture. If there is no spontaneous movement, you may need to apply a painful stimulus, as previously discussed. Classify the resulting pattern of movement as normal, avoidant. The patient pushes the stimulus away or withdraws, or stereotypic. The stimulus evokes abnormal postural response of the trunk and extremities, or flaccid paralysis, or no response at all. Okay, to continue with your neurologic evaluation, you can also test the muscle tone by grasping each forearm near the wrist and raising it to a vertical position as shown in this picture. Note the position of the hand, which is usually only slightly flexed at the wrist. The hemiplegia of a sudden cerebral accident is usually flaccid at first. The limp hand drops to form a right angle with the wrist. So let us now move on to the abnormal postures in comatose patient. We have here decorticate rigidity. In decorticate rigidity, the upper arms are flexed, tied to the sides with elbows, wrist, and fingers flexed. The legs are extended and internally rotated. The feet are plantar flexed. This posture implies a destruction lesion of the corticospinal tracts within or very near the cerebral hemisphere. When unilateral, this is the posture of the chronic spastic hemiplegia. So, another abnormal posture in comatose patients, we have what we call hemiplegia or early hemiplegia. wherein a sudden unilateral brain damage involving the corticospinal tract may produce a hemiplegia or one-sided paralysis, which early in its course is flaccid. Spasticity will develop later. The paralyzed arm and leg are slack. They fall loosely and without tone when raised and dropped to the bed. Spontaneous movements or response to noxious stimuli are limited to the opposite side. The leg may lie extremely rotated. One side of the lower face may be paralyzed and that cheek pops out on expiration. Both eyes may be turned away from the paralyzed side. Another abnormal posture in comatose patient, we have heard this cerebrate rigidity, or known as abnormal extensor response, wherein the jaws are clenched and the neck are extended. The arms are adducted and stiffly extended at the elbows, with forearms and of course pronated, the wrists and the fingers flexed. The legs are stiffly extended at the knees, with the feet plantar flex. This posture may occur spontaneously or only in response to external stimuli such as light, noise, or pain. This is usually caused by a lesion in the diencephalon, midbrain, or pons, although may also arise from severe metabolic disorders such as hypoxia or hypoglycemia. Okay. So now let's move on to another special techniques to check for meningeal signs. This test is important whenever you suspect meningeal inflammation from meningitis or subarachnoid hemorrhage. So, check for the following: neck mobility or nuchal rigidity, Brudzinski sign, and Kernig sign. To check for the neck mobility or nuchal rigidity, first, make sure that there is no injury or fracture to the cervical vertebrae or the cervical cord. In trauma settings, this often requires radiologic evaluation. Then, with the patient in supine position, you have to place your hands behind the patient's head and you can flex the neck forward, if possible, until the chin touches the chest. Normally, the neck is supple and the patient can easily bend the head and neck forward. Neck stiffness and resistance to flexion in 84% of the patients with acute bacterial meningitis and in 21% to 86% with subarachnoid hemorrhage. Brudzinski sign: as you flex the neck, you have to watch the hips and the knees in reaction to your maneuver. Normally, they should remain relaxed. So, as shown in this picture, this is Brudzinski's neck sign. So, flexion of the hips and the knees is a positive Brudzinski sign and suggests meningeal inflammation. So, to check for Kernig sign, flex the patient's leg at both the hip and the knee, and then straighten the knee. Discomfort behind the knee during full extension occurs in many normal people, but this maneuver should not produce pain. Pain and increased resistance to extending the knee are positive Kernig sign. When it is bilateral, it could suggest a meningeal irritation. Compression of the lumbosacral nerve or lumbosacral nerve root may also cause resistance together with pain in the low back and the posterior thigh. However, only one leg is usually involved. Okay, moving on to reducing risk of diabetic peripheral neuropathy. We know that diabetes causes several types of peripheral neuropathy. Therefore, maintaining optimal glycemic control can prevent or delay the onset of neuropathy, particularly from type 1 diabetes. So, distal symmetric sensory motor polyneuropathy is the most common type of diabetic neuropathy. It is slowly progressive, often asymptomatic, and a risk factor for ulcerations, arthropathy, and amputation. So, mas delikado, no? Hindi kasi napapansin. Symptomatic patients report a burning electrical pain in the lower extremities, usually at night. So, the autonomic dysfunction or mononeuropathies and the polyradiculopathies, including diabetic amyotrophy, usually causes unilateral thigh pain and proximal lower extremity weakness. So, remember that patients with diabetes should have their feet examined regularly for neuropathy, including testing pinprick sensation or ankle reflexes, vibration perception, and plantar light touch sensation, okay? As well as checking for the skin breakdown, poor circulation, and musculoskeletal abnormalities. These are the steps for the monofilament lip examination. First, you have to explain rationale for examination, then remove the patient's shoes and socks, demonstrate what monofilament feels like on the hand and the arm. Ask the patient to respond yes each time she or he feels pressure on monofilament. Have the patient close their eyes and hold monofilament perpendicular to the patient's foot. Now press monofilament until it bends in a C shape on designated areas. Hold the monofilament in place for 1 to 2 seconds. Press so it buckles one of 2 times, say time 1 or time 2. Patier identifies time foot was touched. Randomize the site sequence and test plantar surface of distal hallux and third toe. First, third, fifth, metatartal heads. Avoid ulcers, calluses, and corns. Now, in recording your findings, you have to record the following: the mental status, the cranial nerve, the motor, the sensory, and the reflexes you've gathered during your health history or during your physical examination. This ends our second topic for this week, and again, this is the reference. So before I finally end our topics for this semester, let me share to you this Bible verse from Jeremiah chapter 29 verse 11. For I know the plans I have for you, declares the Lord, plans to prosper you and not to harm you, plans to give you hope and a future. May God continue to bless us all and guide our ways. Thank you, everyone. Have a wonderful and a blessed day to all of you. God bless to your final examination. I hope all of you will be able to pass all your subjects for you to be able to move to the next level, to level 2. Again, thank you so much.